Introduction, and thank you all for coming. Today I'm going to talk about, switch gears like nearly entirely and talk a little bit about the clinical treatment of metastatic prostate cancer, something I do in the clinic on a regular basis. These are my disclosures. This is very complete. This is everybody I've ever worked with my entire life. I keep it updated. Really nothing is particularly relevant, frankly. What we'll talk about first is treatment for patients with prostate cancer who are metastatic upon diagnosis. And you'll see a common theme, right? So the common theme is in that setting, early treatment with chemohormonal therapy or with hormonal therapy plus next generation hormonal therapy produces a large survival benefit down the road, actually. And there's 4 trials that talk about that, only talk about 2. The treatment of metastatic castrate-resistant prostate cancer has become a little bit more complicated. There are 6 FDA drugs in this, FDA-approved drugs in this setting. And if you do the math, 6 factorial is 720 different possible sequences if you use all 6 drugs. If you use only 5 of the drugs, then it gets to be a little bit less, actually. But if you add up all the possibilities of FDA-approved drugs that men can be treated with metastatic disease, it's actually over, it's nearly 2,000 different possible sequences and or combinations in that setting. And you can just, by thinking about that, you can realize that it's going to be a little challenging to do long-term survival trials in that kind of setting. I'll talk a little tiny bit about using next-generation anti-androgens earlier. And then finally, hopefully I'll have a little time to talk about my favorite subject, which is, of course, immunotherapy. I'll talk a little bit about ProstVac. There was some news on the large trial this morning. And then I'll talk about some of the ideas of using checkpoint blockade in men with metastatic prostate cancer. So this trial, actually, this is the idea is when patients come in with metastatic disease, the standard treatment has often been hormonal therapy, but what if you gave the chemotherapy that's shown to be effective that Dr. Cardo showed you, actually, docetaxel in an earlier study. This is called the CHARTED study. It was actually proposed in a sort of boring way, I have to say, by Chris by Chris Sweeney when we were at an ECOG meeting many, many years ago. And basically his presentation, his shtick was like, listen, we just got to try this. We got to try it now. We got to start it now. This was about 2007. I know because I was at that meeting presenting a concept for a vaccine trial in prostate cancer, for which the company eventually went out of business. So his trial was eventually published. And this is it's really simple. Men with metastatic disease come in and they're randomized either to standard hormonal therapy or to hormonal therapy plus 6 cycles of chemotherapy. And the results are rather stunning, honestly. Men who are treated with the chemohormonal therapy have a survival that's at least a year longer than men who are treated with hormonal therapy alone. What's a little bit interesting about this trial and these data in common clinical practice is the subgroup analysis, which was based on a stratification factor but was not completely pre-planned, is that it really looks like the benefit is primarily in men with higher volume disease. So men with higher volume disease have much greater than a year survival advantage if you give chemohormonal therapy up front versus hormonal therapy alone. Although there's an argument against this, right? So we presented these data at the consensus conference, and Susan Hallaby pointed out that statistically this is reasonably underpowered. It's a retrospective analysis, and we had a beautiful debate on whether you should use chemohormonal therapy in low volume men or not, actually. I think that these retrospective data, although they're retrospective, are somewhat compelling, and I think that in clinical practice, men with low volume disease are less likely to wind up getting chemohormonal therapy as their upfront treatment. This trial was started about the same time, actually. So, you know, just because it came out later, it doesn't mean that it didn't start around the same time. This was run by Karim Fizazi, actually, and this is a trial saying, what if you give second-generation anti-androgens, particularly Abiraterone, in the same kind of setting? Can you have a survival advantage? So this, again, men with metastatic prostate cancer at diagnosis, randomized either to standard hormonal therapy plus a placebo, or the same thing, adding on a next-generation anti-androgen, abiraterone acetate. These data were presented at ASCO this summer and recently published, and the answer is it's almost exactly the same, okay? So the idea is you can use 6 cycles of docetaxel for upfront metastatic men with hormonal therapy, get about a year and a half survival advantage, and about the same exact thing if you used abiraterone acetate up front. This is continuous treatment with abiraterone plus prednisone. The prednisone is 5 mg a day, 2.5 BID. And so patients are on this oral medicine for many, many, many years. And what was one thing that was surprising from these data was that there didn't really look like a lot of cumulative toxicity. The dose of steroids here is actually less than has been shown in the rheumatologic literature to be associated with immunocompromise or long-term side effects, so maybe that's the reason. But still, it's an interesting discussion you have with men who come with metastatic disease, right? So they come in and you say, listen, hormonal therapy is probably not enough, and you have two choices. One is you can go for chemotherapy. It's 6 cycles every 3 weeks. You'll be done in about 30 months or so, about 30 weeks or so, or you could stay on an oral drug for the next many, many years. And it's interesting, actually, the way it goes with different patients. But either is now a standard of care for sure, actually. This is the overall survival rate at 3 years, clearly significantly better if you use hormonal therapy, next generation hormonal therapy in this setting. So what about castration-resistant disease? This is the PCWG2 criteria. Patients have to be castrated to have castration-resistant disease. I have to tell you, I'm still a little surprised in my clinic where you get patients who come in with a diagnosis of castration-resistant disease, and you check their testosterone, and they're not really castration-resistant because they're not really castrated, actually. So they might have a low testosterone. It might be 100 or something like this, but they're patients who come in with a diagnosis of castration-resistant disease are not castrated. It's not that often, but it's not something that doesn't happen. To have castration-resistant disease, you have to be castrated. Patients have to be castrated, and then they have to have resistant disease. Resistance is a logical or. It's not an and. So either a rising PSA with 2 consecutive rises measured at least 2 weeks apart, soft tissue progression on scan, or 2 new lesions on bone scan. For castration-resistant disease, these are the 6 drugs that are approved. I'm going to go through each one reasonably quickly and then talk a little bit about what that means at the end, actually. So the drug that was immunotherapy that was approved is called Sipuleucel L-T or Provenge. This is an autologous vaccine. It's made from patients' own cells. It's a little bit cumbersome clinically. Patients need to go through a leukapheresis. They undergo leukapheresis. I think this is a pointer. Maybe this will work. They go through a leukapheresis. Their cells are harvested. They're shipped to Atlanta. In Atlanta, basically, they're cultured with this construct that blends the target antigen, prostatic acid phosphatase, with GM-CSF. This actually matures the dendritic cells into vaccine cells, and it makes them present on their HLA, which you just heard a lot about, the protein prostatic acid phosphatase. So the idea is this is a vaccine against prostatic acid phosphatase. And what you hope happens immunologically, and you've seen some immunological diagrams, is that this is an activated antigen presenting cell. This is a dendritic cell. So on its class 1 MHC, it's presenting antigen to CD8 cells. It's also presenting antigen to CD4 T cells. These are ones that are missing in patients with HIV. These provide help. And if you're really, really lucky, and something really happens nicely, which doesn't usually happen, the CD8 T cells can traffic throughout the body and then lyse metastatic tumor cells. This is really not what this usually happens. What usually happens is the clinical trial showed, this is the phase 3 clinical trial, randomized patients to the vaccine versus placebo. And you already saw the data. This is a small survival advantage. With this drug, there are almost, not none, but there's very few patients who have an objective response. PSAs very rarely go down. It's not unheard of, but it's certainly less than 5%, probably more like 1 or 2%. The survival advantage is in the range of 4 months. So that's a big contrast, right, compared to what I showed you before. So if you use chemohormonal therapy up front or hormonal therapy plus next generation hormonal therapy up front, you get a large survival advantage. This is about 4 months survival benefit, actually, although it's statistically significant. Clinically, in real life, what people do with this drug, and I think this is a common practice, if you're going to use it, the idea is to use it early. Retrospective analysis have suggested that it works better with a lower PSA, and also not to expect or have the patient expect that they're going to have an objective or a PSA-based response. And then the patient says, and the physician always says, well, okay, then how do you know that it helped? And the answer is on an individual basis, we really don't have any way to know that. We did publish a paper showing with this vaccine that patients do develop immune responses against the target antigen. And it's interesting, patients who do better seem to develop immune responses against other antigens, right? So this is a vaccine against prostatic acid phosphatase. We're able to detect at the antibody level antibodies to PSMA, PSCA, some other target antigens. So the idea is that maybe when it works, it sets up a broad immune response that sort of slows down the tumor from progressing. And again, this is FDA approved and it's still out there, actually. The drug that really changed treatment of metastatic castrate-resistant prostate cancer is Abiraterone acetate. This is an inhibitor of the enzyme CYP17, which basically leads to fairly profound suppression of steroid synthesis. Particularly testosterone goes down to like less than 5, sometimes as low as 0. It had to be detected by mass spec on some of these studies. What it does, though, it's this profound suppression of these enzymes leads to these feedback loop that looks like a little bit like a fluid retention hyperaldosterone picture. So patients can become fluid overloaded and hypokalemic, actually. So that was a problem, and actually that was one of the reasons the drug was initially slowed down in development. It turns out if you use low-dose steroids, prednisone at 5 or 10 milligrams a day, or inhibit mineral corticoids, you can safely give this drug. And this is the, honestly, in the current clinical practice, Abiraterone is usually used before chemotherapy. So that's why I'm showing this order, right? So if patient's eligible for CYP-T, that's probably what you think about first, or interested in CYP-T. Next, you think about one of the next generation anti-androgens. No particular order, depends a little bit on where you're at. So this is the study, the pre-Docetaxel Abiraterone called Cougar 302. 1-to-1 randomization, Abiraterone plus prednisone. Here is 5 BID versus placebo. And here you see a different thing, actually. I mean, the survival benefit is real. It's statistically significant. It's also in the range of months, but not years, actually. So this is a drug that's FDA approved. Side effects, actually, are those that I just told you about. So mineral corticoid excess, edema, hypokalemia, hypertension. You need to check the potassium, especially when patients first start. Some patients do develop hypertension. It's not that common, or LFT abnormalities. This is a deeper hormonal therapy, though. So these are men who are progressing on Lupron or an LHRH agonist. And so what happens is they have more side effects, actually, of hormonal suppression. Most patients will tell you that they have more hot flashes. And perhaps some of the symptoms they're already having from hormonal therapy are, in fact, magnified. The other drug that's commonly used in this setting is enzalutamide, actually also called Xtandi, rhymes with candy. This is a powerful androgen receptor blocker. So this is sort of like, some people say it's like Casodex on steroids, but basically it binds to the androgen receptor about 5 times as potently as Casodex does. It causes the androgen receptor not to be able to translocate into the nucleus, so it doesn't send its signal. It actually can bind to it and lead it to its degradation. And then finally, within the nucleus itself, it can block the androgen receptor from hitting its target genes. So there's a couple ways that this can work, and it's a powerful, oral, potent anti-androgen. And really, honestly, you can think of it as Casodex on steroids, frankly. This is the pre-Docetaxel trial published by Tom Beer. Again, fairly simple trials. I'm showing you these large trials. Enzalutamide 160 a day versus placebo. It's interesting, this dose, I'll have to tell you, actually. So this is the dose that was in the phase 3 trial. This was dose escalated to tolerability. It's not 100% clear from those dose escalation data that that's the dose that you need to really inhibit signaling. If patients have side effects of this drug, and actually it's in the label, often do dose reduce and do just fine. I've recently inherited, this is editorializing, but I've recently inherited a number of patients from a person whose practice is a bit of an alternative pathway to treat prostate cancer. And this person actually feels very strongly that you should titrate this till it stops down, till it stops working, actually. So I've seen patients in my clinic on 40 and 80 of enzalutamide, actually, and doing just fine, actually. So it's surprising to me. That's why I say that, the dose escalation was to tolerability, not necessarily to efficacy. And so actually, dropping it a little bit for side effects makes reasonable sense. These are the overall survival data, actually, showing a clear survival benefit. Really, honestly, almost exactly from what you get from abiraterone acetate. So in terms of the survival benefit, these drugs are reasonably, of course they're different trials, but they're reasonably equivalent, actually. The side effect that really compromises your ability to give this drug in some patients is fatigue. And I can tell you that this is incredibly variable. I haven't figured out anything that predicts this. And it's interesting because in some patients, it's crushing. I mean, some patients actually can't get out of bed. They're completely different people on this drug. And other patients do just fine. They go to work. They have no problems whatsoever. And this is a variable side effect I think that's important to keep in mind when you start this drug. Hot flashes, just like with abiraterone acetate, hot flashes, if they had them, they're probably going to get worse, actually. They're not going to get better. And some other side effects. In some of the trials, there was a report of seizure, but I think that post-marketing data really haven't supported that so well. So again, this is another second-generation hormonal treatment that's often used earlier in the disease course. So what about chemotherapy? There were two phase 3 trials that led to the approval. This one was led by Mario Eisenberger. This is called TAX-327. This was a trial of docetaxel compared to mitoxantrone. This trial also tried a weekly dose. And you already saw the data. This leads to about a 2 to 3 month survival benefit in men with metastatic castration-resistant disease. So again, survival benefits for all these drugs are similar. The weekly docetaxel really didn't look like it had much of a benefit, and so this is part of the package that led to the approval of the Q3 week dosing of docetaxel. I can just tell you, when you get to this point with a patient, this is not a conversation that usually is one that they like to have. I've never had a patient say, actually, at least recently, boy, I'd really like to start chemo right now. It's become more of a struggle with the second generation antiandrogens and with some talk of other kinds of treatments, actually. So although it has a survival benefit, I think what's happening interesting in the clinic, at least in my perception, is it's wind up being underused because, again, patient preference and really a little bit less. The other thing is that patients who are on the enzalutamide and abiraterone wind up being a little bit farther down the line sometimes before they get in a position where they're interested in this drug. There is some sense that maybe this works better on visceral Mets, but although I have to tell you that that's not really supported by data. The data on patients with visceral Mets with both abiraterone and enzalutamide are good. It looks like the response rate is similar, although those patients do worse, actually. Side effects of docetaxel, the one that patients notice are fatigue and also neurotoxicity, peripheral neuropathy. Peripheral edema and hyperlacrimation occur, but they're not as common. Actually, fatigue is the most common side effect. Another taxane was developed. This was actually developed by Ron Polanc, and similar to the data that Dr. Carlos Cordon-Cordero showed you about, what they did was they grew cells, different cells, up in concentrations of docetaxel, and then looked for drugs that would kill those resistant cells. So that's how they developed this semi-synthetic second-generation taxane. It was called Cabazitaxel. Why didn't it come out sooner? This was developed many, many years ago. It turns out there was a lot of confusion about the PK and how to give this drug. And it was given, like, in early trials by continuous infusion. It was given a couple times a week. And then finally, I think the decision, which was a wise decision, was made to say, look, that's not how we give chemotherapy. We give chemotherapy every 2 to 4 weeks. So what would happen if we gave it in a standard chemotherapy regimen? And this pivotal phase 3 trial, TROPIC, was done to see if, like, the cells, if this worked in castrate-resistant disease, actually. This is, again, this is the trial called TROPIC. Patients either had to progress after docetaxel or while on docetaxel, and enrolled about 750 patients in multiple sites. The dose in this trial was 25 mg per meter squared with prednisone, just like docetaxel versus mitoxantrone prednisone. This was a little bit of an interesting thing for the field, I have to say. This trial kind of like rolled under the weather. It wasn't like the most exciting trial. It was a second generation taxane, what was going to happen. But nevertheless, when it was presented at GUASCO by Oliver Sartor a number of years ago, the survival benefit was really fairly impressive for patients who failed docetaxel, actually. So about a two or 2.5 month survival benefit. This is not the easiest drug to give, actually. So there's in addition to the fatigue like that you see with docetaxel, you also see a fair amount of GI side effects and actually underlying diarrhea. Neutropenia is far more common. These patients sometimes need to be supported with growth factors. Fascinatingly, though, something about the PK or the way this drug travels leads to it not causing neuropathy, actually. So it's a little bit interesting. This drug was also tried to be, there were trials trying to bring this up front before docetaxel, and actually they didn't show that it was superior to docetaxel in an upfront setting. So it's really not approved or often used upfront, although it's surprising, because if you would think if the drug can rescue docetaxel resistant patients, then using it earlier might make sense, but it really wasn't borne out by the trials, potentially because of the trial design. This is the last drug that I'll talk about of those 6 FDA-approved drugs for metastatic castrate-resistant prostate cancer. It's called RAD223 or radium-223. This is a fascinating drug. This is an alpha emitter. Alpha particles are large, right? They're helium nuclei. They don't go travel very far. It homes to the bone, and then the idea is that the alpha particles have an effect against tumor cells in the bone. Probably not only that, it probably affects, of course, like everything, the tumor microenvironment in the bone. And it's administered IV every 4 weeks for 6 doses in the trials. This is the Alsimca trial, which led to the approval. Again, a very simple phase 3 trial, RAD223 versus basically a placebo, and a small survival benefit in the range of everything I just told you. Honestly, everything I just told you for metastatic castrate-resistant disease is in the range of 2 to 4 months. That's the kind of survival benefit that all these agents give. This is for men with bone disease, and so this is about 3 months here. What's more significant, I think, honestly, is this drug does have a nice effect against progression of significant skeletal events, actually. So it prevents pathologic fractures, prevents and treats bone pain. So if a patient has purely bone disease and who has and they have pain or symptoms, this is a very reasonable choice. I also have to tell you, I just showed you those things in like the standard order. That's not how everybody does these things. I've seen patients come into my clinic having received this as a first-line treatment. I'm not exactly sure. Basically, probably the rationale is that if it works later, maybe earlier might be better. The treatment number of cycles, which was 6 in that trial, was limited mostly by drug supply. So should you keep treating or not? We don't really know, actually. It's actually a fascinating drug. It also probably has some immunologic effects. It's being tested in several immunological combinations. What's interesting about the side effects is it's really not that toxic to the bone marrow. So you don't see a ton of neutropenia or anemia, thrombocytopenia. You see GI side effects, actually. So why does this bone-targeted agent have GI side effects? That's another thing I'm not particularly sure of, but it's interesting because if you don't tell your patients that they might have nausea or some diarrhea, they're often a little bit surprised by this. But again, it's a very reasonable drug, particularly for bone-only disease, particularly for palliation, and it's one of the 6 FDA-approved drugs for prostate cancer. There's also, this title is a little bit wrong, there's also an effort to bring some of those next-generation anti-androgens earlier, right? So there's a trial, 2 trials called STRIDE and TERRAIN, which are not on this slide, that both showed if you use enzalutamide in the earlier stages of disease, you see a much better effect in survival. So these are trials that are bringing those hormonal therapies earlier. This is non-metastatic castrate-resistant. This is a next-generation enzalutamide. It's called apalutamide. It must be better because an apple is better than whatever an Enza is. So an apple a day is better than an Enza a day. This is, there's a little bit of excitement for this drug because it theoretically doesn't cross the blood-brain barrier. So maybe that fatigue that we see with enzalutamide will be mitigated by apalutamide. This trial actually is fully accrued, and we should have a readout kind of soon. Prosper is moving enzalutamide earlier. This is the follow-up to the STRIDE and TERRAIN trials. And this is another next-generation anti-androgen. But you have to ask yourself, what does that mean going forward? So if you take a patient who has initial metastatic disease and you treat him with docetaxel 6 cycles plus hormonal therapy, what does that do to the response to docetaxel later on? Or if you take a patient who presents with metastatic disease and you give him abiraterone right off the bat with your hormonal therapy, can you use enzalutamide later on? What happens to the response later on? So it's very, it's a field that's very much clinically in evolution. And it's really hard to tell what the order is to give these drugs, and there's really not any data other than sort of logic and when they were developed about the order of these drugs in patients, actually. So now I'm going to shift gears to talk about my favorite subject, actually, which is immunotherapy. And I actually tell you I have a slightly different take on some of these things, so you're welcome to ask questions at the end and see what you think, actually. So you might have read the news this morning, or you might have not. This is a vaccine for prostate cancer. It's called Prostvac VF. It was developed by the National Institute of Health. And the idea is the vaccine that cured the world of smallpox, right? This is a vaccinia-based vaccine, could be turned into a cancer vaccine. To do that, a cancer antigen, prostate-specific antigen, was encoded and included with this viral antigen. The other thing is that vaccinia vaccines were designed to cure the world of smallpox by raising what? Antibodies, not T cells. We think that T cells are the primary cell that is important in killing tumor cells. And so to make this a better T cell vaccine, they included these 3 co-stimulatory molecules, which in preclinical models showed a much better T cell response. So this is Prostvac, again, with PSA. And some people call this TRICOM because it's a triad of co-stimulatory molecules. So that's where TRICOM comes from. This was tested actually in many, many trials alone, a combination. And there was particularly a trial it used to be owned by a company called Therion that showed that in a small trial there seemed to be a survival advantage. This is kind of immunologically how it works. It's fairly similar, right? I mean, actually, all immune responses that are T-cell based kind of, you could draw the same diagram. So basically the idea is the vaccine affects epithelial cells, they undergo degradation. The products of that degradation help to mature immature antigen-presenting cells to mature cells, and then they present the target antigen. In this case, it's PSA to both CD4 and CD8 cells and hopefully lead to lysis. PSA is an interesting choice as an antigen. Immunologically, I'll just point out that one really, really kind of exciting or fun experiment you can always let your graduate students do is, can you tolerize a mouse, right? So can you make a mouse tolerant to any particular protein? And the answer is yes, of course, it's quite easy. What you do is you take a low dose of that antigen in a soluble form and you provide it continuously over time for about 3 or 4 weeks, and then the mice are permanently tolerized. So PSA is in the blood. It's basically non-inflammatory. So is there tolerance to PSA? It's an interesting question. This vaccine has never raised antibodies against PSA, but there are some data suggesting T-cell responses. This is the phase 3 trial that was conducted in multiple sites across the world. This was a very beautifully designed trial, so it's first line, metastatic castrate-resistant, like no Sipuleucel T, no Abiraterone, no Enza, no chemo, no nothing. First line, metastatic castrate-resistant, randomized either to the vaccine, which was the Prostate Tricom. A little bit of this GM-CSF is used to help activate dendritic cells. But then there was a suggestion from Craig Slingloff and other groups that maybe that's a bad idea. So there was another arm without the GM-CSF. So there's Prostate plus the GM-CSF without versus placebo. And this morning we heard that this trial was stopped actually due to futility. This was an overall survival endpoint. We haven't seen any of the data. They're all blinded, actually. The one thing that to keep in mind is this was a 1,200 patient trial all over the world. And so what I just showed you might matter, right? So in the United States, patients might get 4 or 5, maybe even 6 of those drugs, whereas in Eastern European countries that are just expanding their health care, they might have docetaxel or maybe not anything else, actually. So that's one vaccine. This is a little different than you just heard, okay? So this is adaptive immune resistance, and this is why we think that PD-1 and PD-L1 is one of the primary inhibitions to an anti-tumor immune response. So the idea is if you have a tumor cell, and it does have to have class 1 MHC, so it has to be HLA positive for this to work, okay? So we agree on this part 100%. If a T cell comes in and sees the tumor, recognizes its tumor antigen, what it does is upregulates PD-1 as a brake. And PD-1 is a consequence of seeing the target antigen. PD-1 does not mean the T cell is exhausted. I'm going to say that again. PD-1 is not a characteristic of exhausted T cells. PD-1 is a characteristic of T cells that saw their antigen, right? So these T cells came into the tumor and they saw their antigen and they put on PD-1. If you look at T cells that infiltrate tumors, normal tissues, which are rare, guess what? They also upregulate PD-1. So PD-1 goes up when T cells infiltrate tissues and recognize their antigen. It's actually not particularly specific to cancer. The idea is that this is a mechanism that inflamed tissues use to turn off that inflammation, and tumors have hijacked it. Just having PD-1 means nothing. Actually, the only reason it works is because when the target tissue, either a tumor cell or an epithelial cell or a myeloid cell upregulates PD-L1, that's the break, okay? So PD-1 does not mean a T cell is off. PD-L1 binding to PD-1 in the appropriate condition does mean that the T cell is non-functional. If you block that interaction with anti-PD-1 or anti-PD-L1, this is sufficient to induce an anti-tumor response in 30% of melanoma patients, 20% of lung cancer patients, 15% of patients with 15 or 20% of patients with kidney cancer. So this is probably the primary break turning off the immune response in many patients with cancer. Certainly not all, and certainly not in all kinds of cancers, but this is a primary break, actually. Why doesn't it work in prostate cancer? So one thing, and I think that you heard a little bit about this already, and this is a pathology kind of thing, is if you look at head and neck tumors where, again, the drug has about a 20 or 25% response, they're beautifully infiltrated with these immune cells. This is from my friend Angela DiMarzo. But when you look at prostate cancer cells, they're fairly sparsely infiltrated. The number is 100. It's 100 cells per millimeter squared of tumor. We've actually quantified this across hundreds of patients, actually, so they're sparsely infiltrated. And so it's no surprise that in this phase 1 trial that enrolled 17 patients with prostate cancer, there were no responses. But I would like to point out that in this trial, there were complete responses in other tumors, actually. And some of these patients on this trial are now alive 10 years from now with a complete response. So 2 of the kidney cancer patients I took care of are alive and well. One is at 10 years and one is at almost 8 years now, actually. So does that mean that the immune cells were able to kill those stem cells? Does it mean that maybe they reach the state of détente, where there are some immune cells battling those stem cells? We don't know, but certainly in some patients there are complete responses that last a very, very long time. But not in prostate cancer, actually. So in prostate cancer, we saw nothing, no evidence of objective responses whatsoever. Recently, though, a woman named Julie Graff at Ohio State University, and she and I discussed it, she came up with this trial idea based on an anecdote. So the anecdote was they had a patient who was on enzalutamide, on Xtandi. And this was one of the earlier trials, not the phase 3 trials, that were written fairly liberally, right? So the patient had progressed on Xtandi, and she and Tom Beer gave that patient Sipuleucel LT. The patient went into a complete response and remains in a complete response even to this day. So based on that, we came up with the idea that maybe what would happen if you added anti-PD-1, in this case pembrolizumab, to patients who are progressing on enzalutamide. So the very simple trial, it was 30 or so patients. The idea was she was going to start it in in Oregon State, and we were going to open it up at Hopkins. But last summer, Julie called me, and she's like, yeah, Drake, don't bother opening. I was like, really? Because like we're just, all right, Hopkins IRB was very slow. It's like, you know, we're just working through IRB now. She goes, no, we have objective responses, and we're gonna fulfill the entry. We're gonna complete enrollment on the trial before you even can open. I was like, that's great. So she wound up writing this up actually, and it turns out that in this setting, at least in this setting, immunotherapy can have objective responses in prostate cancer. So these are patients on enzalutamide to which anti-PD-1 pembrolizumab is added. These are the PSA data. Some PSA is dropping from 2,500 to undetectable. Really clear. Patients had measurable disease. It mostly had partial responses or responded. We went through actually and looked at the patients who responded, and we sequenced some of these patients at Hopkins, and she's going on to sequence with her group, and I think with Dr. Nelson's group, some more of the patients actually. And it turns out that it looks like responses are focused in the patients who have mutations in the DNA damage repair pathway. Dr. Nelson will tell you a lot more about that later. So that might be a biomarker for patients with prostate cancer who can respond to immunotherapy, to a T-cell class 1 MHC directed pathway. So we don't really know now how long these responses, many of these are persistent, but how long they're going to last. You know, but certainly some patients do have a T-cell mediated, T-cell MHC, HLA response in prostate cancer. Based on these data, there was an ambitious leap of faith by a company called Genentech, actually, inspired by a dynamic individual named Tom Powles. So basically, they jumped right to phase 3, right? So they said, let's take patients who are progressing on abiraterone acetate, and what we're going to do is we're going to either do that combination, enzalutamide plus their PD-L1 antibody, which is called atezolizumab, or enzalutamide alone. This is a little tricky trial, right? So the response rate to enzalutamide after abiraterone is not great. It's between 10 and maybe 12% on a good day. And so this is not really that great of a treatment path for patients who wind up on this arm. They wind up on it for a short time. Really, probably chemotherapy is more standard in the setting, and the entry criteria are patients have to refuse chemo to go on this or agree to delay chemo. This is also not the same experiment that Julie did. So that experiment was patients who responded to enzalutamide and who were progressing on enzalutamide. Then you add the immunotherapy with anti-PD-1. This is a different experiment. This is what if you give them at the same time. Nevertheless, this trial is open and accruing. I think we adjusted I'm on the steering committee for this. I think we adjusted the numbers a little bit actually, and it's going well. The reason that abiraterone was chosen as the hormonal therapy of choice is this is a Eurocentric trial. It's actually in Europe. It turns out that abiraterone is commonly used as the first-line next-generation hormonal therapy. In the United States, it's really a mix, maybe a little bit more enzalutamide. So I'll end the talk, actually probably close to on time, so we have time for questions, with a quiz. So here's the quiz, and you have to raise your hand, okay? Everybody has to participate, everybody had coffee. So how many immunotherapies are currently approved by the US FDA for the treatment of prostate cancer? So it's very simple. How many people say one? Raise your hand if you think there's one. I only have one. Pete Nelson, actually. Okay, how many people say 0? Okay. Okay, one person says 0. How many people say 2? Dr. Sewell, we got, how many, it looks like there's going to be a lot of D. How many people say, I'm not sure, I don't know what the heck you're talking about? All right, we'll tell you the answer. So there was some unclarity, so that's why it's a good question. It turns out the right answer, Dr. Sewell, of course, being the scientific director of the Prostate Cancer Foundation, knows the right answer. There are 2, actually. So the immunotherapy that's FDA approved for prostate cancer, the two of those are Sipuleucel-T, right, which I told you was FDA approved a while ago. But recently, approval was granted to anti-PD-1 pembrolizumab for patients who have cancer that has microsatellite instability. There are a reasonable number of prostate cancer patients, somewhere between 3% and 5%. Actually, estimates vary depending on the group, actually, but it's at least 3% of prostate cancer patients have microsatellite unstable disease. And you can see here, prostate cancer patients can have complete response to anti-PD-1 pembrolizumab if they have microsatellite unstable disease, actually. A number of additional patients have been treated. And actually, I showed you one of the patients that was treated on Julie's trial also had microsatellite instability. So I think, just in oncology in general, that patients who present with later stage disease, if it's possible, and it probably should be possible, should be typed for microsatellite instability. There are a number of ways to do that. One is by IHC for MSH2 and 6. Another is sequencing the tumor. You can see tumors that have a higher mutation rate, and there's also a PCR-based test. But I have to say that when patients present with metastatic cancer, really of any type, honestly, they should have typing for MSI, because if they do have MSI, they have a good chance of responding to anti-PD-1, either pembrolizumab, nivolumab, or one of the other drugs with long, durable responses, actually. And I think it's a point that I wanted to make at the end. And it's good, nobody got it right except for Dr. Sewell. So again, there's 2 FDA-approved therapies for metastatic prostate cancer, but this is really disease agnostic and only for MSI patients. So take-home points. Early treatment produces a clear survival advantage in multiple patients, actually. Next generation's anti-androgens, really they're going to wind up moving earlier. They're going to wind up moving to early BCR, biochemical relapse. They're going to wind up moving earlier, actually, over the next couple of years. There's already efforts from the STRIDE and TERRAIN trials to do that. In the setting of what I was supposed to talk about, metastatic castrate-resistant disease, there are 6 drugs. I showed you a logical order, an order that's similar to what probably happens in the clinic with most patients and physicians, but not necessarily sure that's the right order. And again, there are many, many possible treatment pathways. I showed you that there's a phase 3 trial of enzalutamide plus atezolizumab. What I didn't show you, actually, and I thought I was going to run out of time, is the other anti-PD-1, pembrolizumab, is being tested post-chemo in a trial called K199, which I'm involved with. And then there's also another trial combining that drug, pembrolizumab, with either chemo or a PARP inhibitor. I really avoided talking about PARP inhibitors because that's what Dr. Nelson is going to tell you about later. Although I have to say that there are some intriguing data combining immunotherapy with PARP inhibitors, suggesting a combinatorial effect. Finally, I talked about the 2 drugs that are FDA approved at the current time. So with that, I'll stop. Oh yeah, I should acknowledge people. So a lot of these clinical trials I hate to make and find. So my friends Emmanuel and Kareem and James and Cora, these folks actually contributed some of those clinical trial slides. I didn't really get to show a lot of data, but these are our collaborators at Hopkins who are really wonderful, actually. I'd like to thank you for your time. Appreciate it.